We continue chapter 19, cardiovascular system, heart. Here is your table of contents. And we are starting from the conduction system of the heart. For our heart muscles to contract, they should receive an electrical impulse. And there is a network of arrhythmic cells inside of the heart that initiates and distributes impulses to coordinate the depolarization and contraction of the heart. It means there is a special network of cells inside of the heart producing electrical impulses that make heart muscle to contract, and it's called conduction system of the heart. It starts right here in the walls of the right atrium, superior and posterior walls. And right here we have what is called sinoatrial node or pacemaker. It's a clump of myocardial conducting cells that generates electrical impulses about 70 times a minute, which is called sinus rhythm, and that's how many times per minute our heart on average contracts and beats. The normal range for heart rate would be 60 to 100 times per minute, and it depends on an age, sex, of individual body size, and many other things. So as you can see, our heart doesn't need any signals from the nervous system to contract. Our pacemaker is doing it for the heart. Depolarization happens faster than any other part of the myocardium. Next one would be atrioventricular node, part of the cardiac conduction system. It's also located in the right atrium, in the inferior portion of it, and it's in the atrioventricular septum. It's a part of the wall separating right atrium from the right ventricle. Here it is. It delays electrical impulses that it receives from sinoatrial node approximately for 0.1 second. Why? So atria, both right and left, would have a chance to contract before the ventricles start contracting. That makes a lot of sense. Atria contract and push the blood to the ventricles. Ventricles should contract a little bit later. So, if something happens with our pacemaker, sinoatrial node, then atrioventricular node will be able to contract only approximately 50 times per minute, much slower. Electrical signals then go through atrioventricular bundle, or it's also called bundle of His, and go to the ventricles. And that is the only electrical connection, between the atria and ventricles. Then that bundle separates into right and left bundle branching. Both of them go through the interventricular septum to the apex of the heart. And finally, a lot of branches originating from them go into the apex and ventricular walls of both left and right ventricle. They branch into even smaller parts, and we call them Purkinje fibers. And those can depolarize only 30 times per minute. It means it wouldn't be enough for their good heart contraction. So cardiac muscle contraction. Remember skeletal muscle contraction. We have depolarization when sodium is going into the cell through the membrane, and repolarization when potassium is going out. Contraction of cardiac muscle is slightly different. About 1% of cardiac cells are automatic or self-excitable, and gap junctions connecting cardiac muscle cells ensure that heart contracts as a unit. It means that pretty much all the cardiac muscle cells contract at the same moment because electrical signal spreads very fast. A refractory period, especially absolute refractory period for cardiac muscle cell, is long, about 250 milliseconds, and during that period, if a new electrical impulse arrives, cardiac muscle cells will not be able to contract. Again, skeletal muscle contraction. Remember? Depolarization, repolarization. How cardiac muscle cell contraction is different. From the beginning, it looks similar to skeletal muscle. Depolarization opens voltage-gated fast sodium channels in the sarcolemma of cardiac muscle cell. Sodium starts moving inside and changes membrane potential from minus 90 millivolt to plus 30 millivolt. After that, that's where differences start. A depolarization wave in T-tubules causes the sarcoplasmic reticulum to release calcium, and calcium channels in the sarcolemma open. And the presence of calcium makes depolarization phase in cardiac muscle much longer, right here, comparing with a skeletal muscle cell. It's called plateau or depolarization phase. And then we have repolarization right here, when potassium is going out of the cell. So, duration of the action potential and this contractile phase is much greater in cardiac muscle than in skeletal muscle. Homeostatic imbalances. If there are any defects in the intrinsic conduction system, what can happen? Cardiac arrhythmias. It means irregular heart rhythms. Heart can be too fast, too slow, or irregular. Contraction of atria and ventricles can be uncoordinated, or sometimes it can even turn into rapid, absolutely irregular contractions, useless for pumping blood, which is called heart fibrillation, and that is a very dangerous condition. To learn more about cardiac arrhythmias, watch a video, and link is under this video. Next one. What happens if there is a defect in sinoatrial node right here? And the atrioventricular node in this case can take over, and it produces junctional rhythm, which will be 40 to 60 beats per minute. Is it enough for normal heart functioning? No, it's definitely not enough in most cases. If atrioventricular node right here is defective, it can result in partial or total heart block, which prevents or impairs contraction of ventricles. And as usual, before you continue this video, stop and answer questions for part 2.1. Electrocardiogram is a recording of the electrical signal of the heart, ECG or EKG. So it means it's all of the action potentials generated by nodal and contractile cells at a given time. Nodal cells are cells in the atrioventricular nodes, bundle of His, and so on. Contractile cells, those are muscle cells, heart muscle cells. The standard electrocardiograph uses 3, 5, or 12 leads. Those are places on their body where electrodes are applied. And the more leads are used, the more information the ECG provides. What is a normal ACG or AKG? There are 5 points on the ACG that you need to remember. The P wave right here, then Q, R, and S. Together they are called QRS complex, and then the T wave. The small P wave right here at the very beginning of the cardiac cycle represents the depolarization of the atria. Electrical signal is going through the atria, and approximately 25 milliseconds after the start of the P wave, about right here, atria start contracting. Now, QRS complex, that is depolarization of ventricles. Electrical signal is going through the ventricles. And about at the top of R, right here, R wave, that's where ventricles begin to contract. And finally, we have T wave, that represents the repolarization of the ventricles. What about repolarization of the atria when electrical signal leaves atria? It happens during the QRS complex also, so we cannot see it separately. Okay, cardiac cycle, all the events happening during one heart contraction and relaxation. How are they presented on ACG? Let's look at this picture number 1. The heart is relaxed right now. Then, electrical signal at the beginning of the next contraction is initiated in the sinoatrial node, and it causes P wave on ACG. And when atria starts to contract, it happens during P wave and continues right here. That's contraction of atria. Then, depolarization of the ventricles happens at the apex right here, and it causes QRS complex. Approximately at R, ventricles are contracting. And finally, ventricular repolarization, T wave, and then relaxation of ventricles showed in those 2 pictures. Cardiac cycle 1. So the period of time that begins with the contraction of the atria and ends with ventricular relaxation is known as the cardiac cycle. The period of contraction that the heart undergoes while it pumps blood into circulation is called systole. It means atria contract or ventricles contract, that is systole. The period of relaxation that occurs as the chambers fill with blood is called diastole. Atria relax and fill with blood, that is diastole. Depending with which chamber it happens, both systole and diastole can be atrial and ventricular. So again, atrial systole, contraction of the atria. Atria move blood to the ventricles. Atrial diastole, atria relax and filled with blood. Next one, ventricular systole. Ventricles contract and push blood into pulmonary trunk and aorta. Ventricular diastole, ventricles relax and then filled with blood. All the events of the cardiac cycle are presented in picture 19.27 in your book. Let's look at each of them. They are called phases of the cardiac cycle. Phase 1, ventricular filling. It happens when atria are already filled with blood and blood passively goes into the ventricles from atria because atrioventricular valves open, and about 80% of all blood from atria passively goes into ventricles. There is still 20% of blood in atria, and they will be delivered into ventricles during atrial systole or contraction of atria. At the end of that contraction, there will be what is called end diastolic volume of blood in each ventricle. EDV. Next one. Ventricles are ready to contract, and the contraction starts. The first phase of ventricular contraction, ventricular systole, would be isovolumetric contraction phase. That's when all valves are closed. The blood is not moving yet, but the valves are closed already. Then ventricles contract. Second phase of ventricular systole, it's called ventricular ejection phase. Blood is moving into pulmonary trunk from the right ventricle and to aorta from the left ventricle. Blood cannot go back to the atria because atria ventricular valves are closed. And the volume of blood remaining in each ventricle at the very end of the ejection phase will be called end systolic volume, ESV. Next one, atria start relaxing. That would be isovolumetric relaxation. As soon as ventricles start relaxing, the heart needs to prevent backflow of the blood from the pulmonary trunk and aorta back into ventricles. So, semilunar valves close. And when blood tries to go back from aorta to the left ventricle and bumps against that aortic valve, and it cannot go back into the left ventricle, the pressure in aorta goes up for a while, brief rise in aortic pressure, and it's called dicrotic notch. So what are relationship between the cardiac cycle and ACG? Look here, P wave, depolarization of atria, approximately at the middle, atria contract, atrial systole. QRS, depolarization of ventricles, and right here at the peak of R, ventricles start contracting, ventricular systole. And here's your T wave, atria already relaxed, atrial diastole, and at the end of T wave, ventricles relax. When heart is beating, we can hear heart sounds if we use stethoscope, or even if we simply press our ear against somebody's chest, we can hear those heart sounds. They are called S1 and S2, or they often called lub and dub. And they are associated with closing of heart valves. First sound, S1 or lub, it happens when atrioventricular valves close. That is the beginning of the ventricular systole, ventricular contraction. The second sound happens when semilunar, aortic, and pulmonary valves close at the beginning of ventricular diastole or relaxation to prevent backflow of the blood from aorta and pulmonary trunk. Sometimes valves don't work well, and there are some abnormality in their structure, so they let some blood to pass through when it's not necessary, and those sounds are called heart murmurs. To learn more about heart sounds, please watch a video, and the link is under this video. Another chart showing you heart sounds and the cardiac cycle. Right here you can see pressure inside of the heart, and right here you can see heart sounds. So as soon as right here atrioventricular valves close, you can see the first lub sound. As soon as semilunar valves close, you can hear dub sound. Where do you place stethoscope for auscultation or listening to their heart valves? For each valve, there is a best location: aortic, pulmonary, mitral, and tricuspid. And that is a picture from your book, 19.30, but here is a picture with description of exact areas of placement. So, aortic valve, you can listen if you put your stethoscope in second intercostal space. So, first rib, second rib, between second and third rib, right next to the sternum. Pulmonary valve you can hear on the other side, on the left side, also between second and third rib. The best place for tricuspid valve is next to the sternal border in the, look here, first, second, third, fourth intercostal space. To hear the mitral valve or left atrioventricular valve, it will be about 2-3 inches to the left from the sternum, right here in the 1, 2, 3, 4, 5th intercostal space. Before you continue watching this video, please stop and answer questions for part 2.2. What is cardiac output? CO. Cardiac output is a volume of blood pumped by each ventricle in 1 minute. So how we calculate it? Heart rate times stroke volume. Heart rate is the number of beats per minute, how many times a minute your heart beats. And stroke volume, a volume of blood pumped out by a ventricle, which is with each beat, 65 to 75 milliliters on average. So stroke volume is normally measured using an echocardiogram to record end diastolic and end of systolic volume and calculating the difference. How we can calculate cardiac output? On average, heart rate would be 75 beats per minute. Or you can count your own heart rate. Use your pulse. And times stroke volume, on average in humans, it would be 70 milliliters. So, on average, cardiac output will be 5.25 liters per minute. Maximal cardiac output that our heart is capable to produce during exercise usually is 4 or 5 times higher than resting cardiac output. But in trained athletes, it can be way much higher and reach 35 liters per minute. Difference between resting cardiac output and maximal cardiac output would be called cardiac reserve. What factors influence cardiac output? Of course, those would be factors affecting heart rate, and we can name autonomic innervation, either it's sympathetic or parasympathetic, different hormones, level of fitness of the individual, and their age. What factors affect stroke volume? Size of the heart, fitness levels, gender, contractility, duration of contraction, preload and afterload. Let's talk about them. Heart rate. Heart rate varies with exercise and fitness levels. The more you exercise, then lower actually your heart rate will be when you are not exercising at rest. Also with age, newborn heart rate, resting heart rate, maybe 120 beats per minute, and it's absolutely normal. With age, heart rate gradually decreases, and then at the older age, after 60, 70 years old, it increases again. Other factors: gender. Female heart rate usually is a little bit higher than male heart rate. And body temperature. When you have fever, your heart rate will be much higher than when you are healthy. Next one, Autonomic nervous system regulation. In medulla oblongata, there are two cardiovascular centers. Cardioacceleratory center activates our heart through sympathetic neurons and makes our heart to beat faster. Another center, cardioinhibitory center, through vagus nerve, the tense cranial nerve, can slow down our heart rate. Chemical regulation of heart rate. Different hormones can increase our heart rate. Epinephrine, hormone produced during stress from adrenal glands medulla, can increase our heart rate and contractility. Thyroxine, the thyroid gland hormone, also can increase heart rate and increase the effect of epinephrine and norepinephrine. Concentrations of certain ions in our blood can increase heart rate, and substances like caffeine in coffee and nicotine can increase our heart rate. When heart rate is too high, it's called tachycardia. It's when it is higher than 100 beats per minute. It can be absolutely normal when you are exercising, but if you have 110, 120 and higher heart rate during rest, it is not good and there should be some certain causes for that. Bradycardia. Heart rate slower than 60 beats per minute. It can be absolutely normal for high-trained athletes, but in most of people, it may result in inadequate blood circulation and can be a sign of disease. Okay, before you continue, please stop the video and answer questions for part 2.3. As we said before, stroke volume is a volume of blood pumped out by a ventricle with each heartbeat. And stroke volume is equal to end of diastolic volume minus end of systolic volume. Let's remember, end of diastolic volume happens at the very end of their ventricular diastole, when ventricles are dilated, relaxed, and filled with blood. End of systolic volume happens when ventricles contracted completely and they just pushed most of the blood they had into aorta and pulmonary trunk. There are three main factors affecting stroke volume that you need to know: preload, contractility, and afterload. Preload is a degree of stretch of cardiac muscle cells before they contract. There is a Frank-Starling law of the heart that says the force of heart contraction is directly proportional to the initial length of the muscle fiber. It means the more heart muscles are stretched, the stronger they will contract. How heart muscles can be stretched? It means there is a lot of blood inside of each chamber. Blood fills in ventricles and atria, and the more blood is there, the more muscles are stretched, the stronger they will contract. So cardiac muscle exhibits a length-tangent relationship. Slow heartbeat and exercise increase venous return back to the heart, blood to the heart. Increased venous return, the more blood returns back to the heart, the more it stretches the ventricles, and the more ventricles are stretched, the longer will be muscle fibers, and the stronger will be contraction force. Contractility, number 2. Contractility is a contractile strength at a given muscle length, so how strong those muscle fibers can contract. There are two types of agents or factors. Positive inotropic agents increase contractility. As an example, it can be sympathetic stimulation or thyroxine, hormone of the thyroid gland, epinephrine, hormone of stress, or glucagon, hormone of adrenal glands. Negative inotropic agents decrease contractility, make heart contraction weaker. Acidosis can cause it, increased extracellular potassium level, or chemicals that block calcium channels. Afterload is a pressure that must be overcome for ventricles to eject blood. What does that mean? When ventricles pump the blood to aorta, there is already some blood there, and that pressure of that blood in aorta should be overcome. Hypertension can increase afterload, and that will result in increased end-stroke volume and reduced stroke volume. Okay, so here in this table 19.34, there are major factors influencing stroke volume. Look at several examples. For example, decreased thyroid hormones cause low preload. It means that will decrease stroke volume. Thyroid hormones will increase contractility, and by doing that, they will increase stroke volume. Hypoxia will increase contractility, and also hypoxia will increase preload, and that means it will decrease stroke volume. Please memorize several examples of factors that can increase and decrease stroke volume. Congestive heart failure. Condition of the heart, where cardiac output is very low, so low that blood circulation is inadequate to meet tissue needs, is called congestive heart failure. What does that mean? When there is not enough of oxygen that blood delivers to provide tissues with energy, and not enough nutrients. It can be caused by different heart conditions, and by coronary atherosclerosis, persistent high blood pressure that continues for a long time, multiple myocardial infarctions, and finally a condition that is called dilated cardiomyopathy. What is that? Dilated cardiomyopathy, it's when a size of ventricles, especially ventricles and especially the left one, is increased, and the walls are much thinner than they should be in normal heart. So when this heart tries to contract, there is not enough power for those thin walls to pump all that blood in their increased ventricle. That condition can be caused by diabetes, by obesity, high blood pressure, abuse of alcohol, cocaine, and different drugs, certain medications, infections, and exposure to different toxins. What would be symptoms? Lack of oxygen delivered to the tissues can cause fatigue, shortness of breath, reduced ability to exercise at the beginning. Later, it will be difficult for a person even walk on the second floor. It will cause swelling in legs, ankles, and feet, abdomen, and chest pain. And dilated cardiomyopathy can cause death, finally. Please answer the questions for part 2.4.